Well, let's therefore apply these mechanisms to absorption. First point maybe on your exam would be to define absorption appropriately. Maybe choose a statement about absorption. Absorption is about the processes of entry of a drug into the systemic circulation from its site of administration. If you take a drug orally, it's going to need to go across the gut, go in portal circulation, across the liver, and then finally reach systemic circulation. If you were inhaling a drug, well, you would have it to get into the alveolar space. Hopefully it's a small enough aerosol. And from the alveolar space, go across the alveolar membrane and get into the bloodstream this way. You know what it means then. How about giving a drug IV? If I give a drug IV, there's no process of entry that belongs to the body anymore. Literally speaking, I'm just plucking in the systemic circulation of the patient. I'm plucking a needle and pushing the drug directly into the vein. In that situation, it means intravascular administration has no absorption parameter associated to it. Other aspect of absorption deals with the loss of drug. If a drug has to cross many membranes and compartments before it reaches systemic circulation, logic would tell us that not 100% of the dose may reach that systemic circulation. Contrast to IV administration. If you put the needle appropriately in a blood vessel, there is no doubt that everything that's in the syringe is going to eventually reach the blood vessel. Well, we call the fraction of a drug reaching the systemic circulation the bioavailability of that drug. And written in red on your screen is the point that bioavailability is 100% when you give drugs IV. That's a sign that there is no absorption and no loss of drugs. Conversely, the last point would be that it is only with extravascular administration that less than 100% of a drug may reach systemic circulation, and bioavailability will be a parameter to look at for extravascular administered drugs. As we look at absorption with the plot of plasma concentration versus time. Blood is a great specimen to obtain from patients in order to have an idea how much drug is in the body, and often we even try and link certain plasma or blood concentration with a certain effect of a drug, although it's sometimes a little tricky to try and associate blood concentration with the actual responses you see, particularly if those responses are somewhere in tissues like the brain. Nonetheless, the diagram you see is a classic pharmacokinetic diagram that we refer to as a plasma level curve. A plasma level curve plots on the y-axis plasma drug concentration and on the x-axis time. To obtain those curves, you would imagine at time 0 to the far left corner of the diagram, you would administer the drug to the patient and then every so often obtain a blood sample and measure what the plasma drug concentration is at these various time points. Well, linking the points together will give you a classic bell-shaped curve for any extravascular administered drug. Several parameters are shown to you on that diagram. The first parameter shown to you on the x-axis is the parameter of lag. It's not a very important parameter. To get rid of it fairly quickly here, you could imagine that if you were giving a drug orally, it may take a certain time before it reaches the systemic circulation. That's what the lag time is. It is defined as the time it takes for the drug to first appear in the blood. What is much more relevant is that after that lag phase, which may or may not show on your curve, you see classically a rapid increase of drug concentration as a function of time. What this signifies to us is that the drug is reaching the blood much faster than it's leaving it. That's what we call the absorption phase of the curve. A key point is that absorption is not the only thing going on for that drug right now. Rather, absorption is the predominant aspect of the pharmacokinetic. Drug reaches the bloodstream faster than it can distribute, get metabolized, and be eliminated from the body, resulting in an increasing concentration as a function of time. That concentration will eventually peak, and the peak concentration is read on the y-axis at the top of the curve and is referred to as Cmax. Of course, on the x-axis, corresponding to the Tmax, will be the time to peak, which is referred to as Tmax. Beyond the peak, you expect the blood concentration to go down as a function of time, and as it starts going down, it is simply showing you that absorption is no longer the prevalent phase of pharmacokinetic. You could imagine that the beginning of the curve has a great deal of distribution as a main phase, and it's fine if in your syllabus you would write right around the bell shape here that this represents the distribution phase of the actual drug. But beyond distribution, we know a lot of the drug will be metabolized and then ultimately eliminated. We refer to the end exponential tail of the curve here as the elimination curve of that drug. Well, if you conceal the pharmacokinetic parameter by looking at this curve, you could imagine that on the exam we could alter the shape of these curves and ask you what is going on. And if you want, we can try this on the little black board. I'll just try one. Imagine that I give you a plasma level curve, very similar to the one you have on your diagram, and then I superimpose to that plasma level curve a red plasma level curve and ask you what is going on. I think you could see that there is a change in the beginning slope of that curve. How would you interpret that change? If you remember that this is the absorption phase of the plasma level curve, you see that on the red curve there's been a decreased absorption. How could I decrease the absorption of a drug? Well, imagine you were taking a tetracycline antibiotic, and at the very same time you were taking some dairy products, maybe milk with calcium in it. You remember that tetracyclines chelate calcium? Once there would be chelating calcium and calcium being ionized, the drug would be totally ionized. And what happens to drugs that are ionized? Hopefully you're thinking ionized drugs don't cross membrane and they would stay trapped inside the stomach and GI of that patient, thereby decreasing, slowing the absorption of the actual drug. So we can play with the different phases, and as you play with those phases of absorption, you could also play with the phases of eliminations, with metabolism. You can alter that curve and then match it to some key points that we'll talk about particularly later on in the syllabus. Now, besides looking at pharmacokinetic, the diagram plot of plasma concentration versus time also gives you some pharmacodynamic parameters. Particularly, you see a dotted line in the middle of that curve that is referring to the minimum effective concentration. Now, minimum effective concentration has really nothing to do with kinetics, but all to do with how drugs, after binding to receptors, will allow responses. It is defined as the concentration below which there is no effect, above which there would be an effect, hopefully therapeutic, maybe toxic if you were looking at toxic curves. This allows in turn the definition of two critical time points in administration of drugs shown on the x-axis, what we call the onset of activity of a medication and the duration of action of that drug. If we first look at the onset of activity, you imagine that the onset of activity refers to how long it takes for the drug to first have action, to first give a therapeutic effect. This is the time it takes on the curve for the plasma concentration to reach minimum effective concentration, just where I'm pointing the arrow right now. That onset of activity is very dependent on the rate of absorption. The slower the absorption, the more delayed the onset of activity. The faster the absorption, the sooner the onset of activity. Contrast the parameter of duration of action. A drug is going to have an effect that lasts as long as the blood concentration are in excess of its minimum effective concentration. In our diagram here, the entire top portion of the curve are concentrations that are above minimum effective concentration. If you project this on the x-axis, you find that during this period of time, you would have activity of your drug. Duration of action is defined as concentration staying above minimum effective concentrations. What could change duration of action? Surely absorption might have a little effect on it, but you realize that because it encompasses the whole bell portion of the curve, distribution, metabolism, even elimination could alter the duration of action. what do you think a slowed elimination, such as someone with impaired kidney or liver function, would do to the duration of action? I'm sure you're thinking, just like I do, that this would increase the duration of action of your drug, and obviously maybe giving too much effect in the process. Very similar to the previous diagrams of plasma level curve, let's talk a little bit about bioavailability. We're going to define it. We know already it's the fraction of a dose that reaches the systemic circulation, and we know it only occurs after extravascular administration. And we call it F, that fraction. But what I would like to focus on first is the diagram to the right of this slide, the area under the curve for an IV bolus and extravascular doses diagram. What you recognize in that diagram are plasma level curves, very similar to what we just looked at, particularly the one that I'm going to point at with the arrow right here, which has the classic bell-shaped curve with initially an increase in concentration as a function of time because of absorption, a peak called Cmax occurring at Tmax, and a decrease with eventually an elimination curve. This is the extravascular dose. Notice then, importantly, the other plasma level curve, the one that starts on the top left. If you look at this plasma level curve, it immediately starts at a maximum concentration, thereby telling you you've avoided the process of absorption totally. This is obviously the intravascular administered dose of that drug. What you notice is that IV drug start immediately at Cmax, and all you see as processes are distribution, metabolism, and elimination. If you wanted to figure out which fraction of a dose reaches systemic circulation, it would be fairly logical to contrast how much of a dose of drug has been reaching the bloodstream after extravascular administration versus the golden standard, which will be the dose of a drug given IV, where 100% of that dose will have reached systemic circulation. To do this, what people doing pharmacokinetics do is calculate the areas under the curve. On your diagram, areas under the curves, called AUCs, are represented as hatched areas. The extravascular dose is shown as an AUC with vertical hatching. The area under the curve of the extravascular dose is literally in square centimeters if you want, and represents how much drug as a function of time has been transiting through the bloodstream after giving, for instance, an oral dose of that medication. On the same diagram, in horizontal hatching, is the area under the curve obtained after IV administration of the drug. The horizontal hatching represents, again, then, as a function of time, how much of drug given IV has been traveling through the blood, through the body. A ratio will be done between these AUCs, and the ratio will be used to derive the fraction of the dose that reaches systemic circulation. The ratio to be done is the AUC of the extravascularly administered drug, such as PO, divided by the AUC of the IV administered drug. You remember that 100% of the dose given IV has reached the bloodstream, meaning the entire dose, all the milligrams given to the patient IV, are in the bloodstream over time. This should therefore be the largest AUC possible. The AUC extravascular, there might be some losses of drug on the way, so you would expect the AUC PO to be smaller. As a result, F, the ratio, should be at best equal to 1. And if F equals 1, meaning the AUC PO equals the AUC IV, that would be a sign where extravascularly administered drug completely reaches systemic circulation. This is very unusual. Most often, F will be a number much smaller than 1, maybe let's say 0.3. And if F equals 0.3, it means that the AUC PO is only a third the size of the AUC IV, or if you want, the fraction that reaches a systemic circulation is around 30%. Why is it that orally administered drugs classically have low bioavailability? Well, if you look at your next diagram, bioavailability and first pass metabolism, we show you that when a drug is given orally by mouth, first stop is in the stomach. Certainly in the stomach already the acid medium might be enough to destroy some of the drug potentially. We may have to coat the drug for it to survive the acid medium. And then once it gets into the gut, it needs to get through portal circulation to the liver. In the liver, we have most of our metabolism that would be ongoing, and that metabolism may destroy most of the drug before it even makes it to systemic circulation. Bioavailability at the top of your diagram literally is the fraction of the dose that was given by mouth that eventually reaches at the far right of the diagram systemic circulation. And first pass metabolism is the actual fraction of the drug that actually gets destroyed by the liver through metabolism prior to reaching systemic circulation. It is a big player at lowering bioavailability of orally administered drugs. Still related to our section on absorption, a final parameter to discuss is bioequivalence. Bioequivalence is a relevant parameter when you look at two formulations of the same compound. You could think of a generic drug versus the actual trade for that drug. The idea being, maybe generics would be favored because they're cheaper, depending on the health insurance plan of your patient, depending also on what's available in the pharmacy. Can you really use a generic just as well as you could use the trade name drug? After all, it's the same chemical. Well, the idea is formulation of that chemical could very much change the pharmacokinetic parameters. And because of this, if you want to switch from one formulation to the other without having to worry about changing the dose or the dosage regimen, they must have, those two formulations, two key things. They must have the same bioavailability. We know that means the same fraction of the dose administered must reach the systemic circulation, but they also must have the same rate of absorption. If you look at the following diagram, effective rate of absorption on plasma concentration, you're looking right there at an example of bioinequivalence. Essentially telling you what bioequivalence is not. You're looking at two brands of a drug called brand A and brand B, and those drugs, those formulations have different rates of absorption. If you look at brand A on its plasma level curve, you see that it has a very sharp rate of absorption. The increase in plasma concentration is very rapid as a function of time. The same drug in a different formulation called brand B has a much slower rate of absorption. Notice the result. The slow rate of absorption, brand B, as it reaches the blood, pretty much gets distributed, metabolized, and eliminated. And as a result, it never even reaches minimum effective concentration at the dosage used, telling you that brand B is not bioequivalent to brand A. Brand B, with a slower rate of absorption, would require a higher dose to reach minimum effective concentration. Is it the case normally that different formulations or generics versus trade are not bioequivalent? Well, rest assured, it's unusual. Most often, of course, a generic will be exactly like the trade, but some important times it may not be. I'll give you one example that you'll think of for your step 2, dilantin and phenytoin. They really are the same chemical used as anticonvulsant, but dilantin as the trade actually has a very different rate of absorption than the phenytoin generic, so that often we have to be careful what type of dose and how often they would be given. This is it for absorption.